Among pregnant women in Nigeria, the prevalence of iron deficiency anemia stands at 45%. Left untreated, this condition significantly elevates the risk of severe childbirth complications, specifically postpartum hemorrhage and maternal mortality. To mitigate these risks, global health guidelines specify daily oral ferrous sulphate pills as the baseline intervention. But this regimen requires a patient to adhere to a strict schedule of pills every day for 245 days. That length, combined with severe gastrointestinal side effects, leads to extremely low completion rates. The prescribed standard fails in practice. Logistical friction and prolonged discomfort prevent women from finishing the treatment, leaving them highly vulnerable when they enter labor. Intravenous ferric carboxymaltose, or FCM, offers a direct clinical alternative. It replaces the depleted iron rapidly by delivering it straight into the bloodstream. A single 15 to 20-minute infusion completely replaces the entire 245-day oral pill regimen. The barrier to adoption is purely financial. The upfront acquisition cost of FCM is high, putting it out of reach for many health systems in low- and middle-income countries. The IVON trial, conducted in Nigeria, tested a specific economic hypothesis: whether paying for this expensive upfront treatment actually saves the broader health system money in the long run. An analysis of the trial's health economics data demonstrates that accepting higher initial medication costs systematically reduces long-term expenses and prevents maternal deaths. To accurately compare these two interventions, health economists use a decision tree model. This allows us to map the distinct clinical pathways of mutually exclusive treatments. This decision tree visualizes the fundamental trial split. A patient receives the single FCM infusion on the top branch, or the standard oral ferrous sulphate regimen on the bottom branch. Following the bottom path requires 10 scheduled clinical visits and 245 days of treatment. The upper path concludes its intervention on day 1. Both branches eventually converge on one of two clinical outcomes: the anemia is successfully resolved, or the anemia persists. Patients who enter the persistent state face the severe downstream risks of postpartum hemorrhage, which carries a direct statistical probability of maternal death. The probability of reaching those fatal endpoints is directly tied to the structural duration of the prescribed medical treatment. A protocol lasting 245 days has drastically more failure points than a streamlined protocol lasting just 15 minutes. Let's examine the economic burden of each pathway, starting strictly with the pharmacy receipt. This side-by-side ledger shows the stark difference in raw drug acquisition costs. A single FCM vial costs $83.75. The entire oral pill course costs only $30.99. But accurate health economics requires a partial societal perspective to measure hidden human capital costs. The oral regimen carries a heavy secondary drag. Over 245 days, patients incur expenses for unscheduled visits, transport, and massive productivity loss. The FCM pathway requires facility and administration costs for the IV, but because the treatment is completed in a single day, the transport and productivity losses are drastically minimized. When we sum these columns, the final mean cost per woman is $139.71 for the FCM group and $104.33 for the oral group. Upgrading a patient from oral pills to a single IV infusion costs the health system an additional $35.38. Monetizing the true value of human time, lost labor, and transport erases the massive perceived cost gap between the expensive drug and the cheap pills. So, what objective health returns society get for that additional $35 investment? Health economists quantify this using disability-adjusted life years, or DALYs, a metric that measures the combined burden of morbidity and premature mortality. This horizontal chart compares the health loss of the two cohorts. The oral group experiences a significantly higher burden of health loss. Their high rate of persistent anemia and subsequent complications drives their health loss to 0.0377 DALYs per woman. In contrast, the single-dose FCM cohort sees their DALY metric drop to 0.0111. That mathematical drop represents the single-dose treatment successfully stopping the cascade from persistent anemia into severe hemorrhage and death. Paying a slightly higher monetary cost for the IV treatment purchases a measurable, objective reduction in maternal suffering and mortality. We combine the financial ledger and the DALY metric into a single figure for policymakers. the incremental cost utility ratio, or ICUR. This equation calculates the ICUR by dividing the incremental cost difference, $35.38, by the incremental DALYs averted. The result is exactly $1,331.12 per DALY averted. We plot this ratio against Nigeria's gross domestic product per capita, which is $2,078. Because the ICUR falls below this national threshold, the IV treatment is highly cost-effective. However, rigorous health economics requires testing the vulnerabilities of this model through a sensitivity analysis. This tornado diagram identifies the parameters capable of breaking the economic model. The top widest bar represents the single most sensitive variable, the acquisition cost of the FCM vial itself. If the price of an FCM vial rises above $103.61, the ICUR crosses the willingness to pay threshold. At that price, the intervention fails for public funding. The entire macroeconomic viability of this life-saving protocol balances strictly on controlling the upfront procurement price of the drug. Applying these trial data to the macro-level reality of national health infrastructure reveals a clear mandate. Paying significantly more upfront for a single-dose treatment completely bypasses the behavioral and logistical frictions of daily pills and ultimately saves the system money. But the current out-of-pocket cost of the IV vials severely restricts access for the pregnant women who need it most. Ministries of health must negotiate bulk procurement agreements, stimulate local manufacturing, and remove import taxes to lock the vial price permanently below that $103 threshold. Without systemic price controls and direct integration into national health insurance schemes, the mathematical benefits of this treatment remain theoretical. National guidelines for antenatal care must be updated to include ferric carboxymaltose as a primary intervention for moderate to severe iron deficiency anemia. These findings hold significance for resource-constrained nations globally, backed by rigorous international clinical and economic research. Minimizing pharmacy acquisition costs at the expense of clinical efficacy is a false economy. It only increases the total societal burden. Transitioning from oral iron to a single intravenous dose is a mathematically proven, economically sound pathway to reducing maternal mortality.